I'm going to go over this section because the pathophysiology and understanding of the hematologic system is very important to the understanding of hematologic disorders, including cancers of the blood such as leukemia and lymphoma, as well as other problems that cause anemia. This will be up to you whether you review this section or not. It is possibly beneficial if you do so. Possibly beneficial if you do so. When taking subjective health history, you're going to look at demographic data, past health history, past and current uses of medications, surgical history, herbal preparations and nutritional supplements, family health history, and a review of systems using functional health patterns. In addition, you're going to be looking at previous hematologic problems such as anemia, bleeding disorders, or blood diseases such as leukemia. You'll be looking for hepatitis or cirrhosis, perhaps. Recent or recurrent infections or problems with blood clotting also would need to be documented. And you'll ask about injuries to the liver, kidneys, or spleen, and alcohol or IV drug use. Medications are important to assess thoroughly to identify any substances that might potentially influence hematologic health. So you need to take a history about prescriptions, over-the-counter medications, vitamins, herbal products, and dietary supplements, because they have the potential to interfere with normal hematologic functions. So, for example, herbal therapy can interfere with clotting. Anti-neoplastic and antiviral agents might cause bone marrow depression. Previous chemotherapy, especially with alkylating agents, puts patients at a higher risk for developing a secondary malignancy of leukemia or lymphoma. And long-term anticoagulant therapy can increase the risk of bleeding problems. You want to make sure that you ask the patient about specific past surgical procedures, because things like the duodenum is where iron absorption occurs, so if they've had some surgical removal, that could be important. Partial or total gastrectomy removes parietal cells, so it reduces the intrinsic factor that's needed for the absorption of cobalamin or B12. Gastric bypass means the duodenum may be bypassed and parietal cell surface area might be decreased. And an ileal resection is important because that's where the cobalamin absorption takes place. You want to assess how wound healing progressed postoperatively and if and when any bleeding problems occurred in relation to surgery or past injuries, including minor trauma and dental extractions. And you want to determine the number of previous blood transfusions and possible complications during administration, because the risk of transfusion reactions and iron overload increases with the number of blood transfusions. Let's talk about this case study. BC is a 76-year-old female who presents to the hematology clinic where you work. She's complaining of an increase in fatigue over the past 3 months that's not any better after a decent night's rest. Her daughter adds that her mother has nearly fallen twice in the past week while just walking around in her house. Her primary doctor has referred her for further evaluation of her complaints. What are you doing first? Well, a complete health history of the hematopoietic system consisting of demographic data, current health, past health history, past and current use of medications, surgical history, herbal preparations and nutritional supplements, family health history, and a review of systems using functional health patterns would be in order. So in your assessment of this patient, you're going to gather information about age, gender, race, and ethnic background, Family history is very important, especially of hematologic problems, because it helps identify genetically linked disorders, specifically jaundice, anemia, malignancies, sickle cell disease, and other red blood cell disorders, bleeding disorders such as hemophilia, and clotting disorders. Tactfully ask for risk factors such as alcohol, illicit drugs, and cigarette use. Alcohol is caustic to the GI mucosa and can cause GI bleeding, esophageal varices, and decreased absorption of cobalamin and other nutrients, resulting in vitamin deficiencies. Chronic alcoholism can damage platelet functions and the liver, affecting the production of clotting factors and leading to bleeding problems. Many illicit drugs affect hemopoiesis. Cigarette smoking increases low-density lipoprotein, or LDL cholesterol, and levels of carbon dioxide, leading to hypoxia and altering the anticoagulant properties of the endothelium. And smoking increases platelet reactivity, plasma fibrinogen, hematocrit, and blood viscosity. Obtaining the patient's weight and determining if the patient has experienced anorexia, nausea, vomiting, or oral discomfort. You're also going to take a dietary history that includes clues about the cause of any anemia, such as iron, cobalamin, and folic acid being necessary for the development of red blood cells. Iron and folic acid deficiencies are associated with inadequate intake of foods such as liver meat, eggs, whole grain and enriched breads, and cereals, potatoes, leafy green vegetables, dried fruits, legumes, and citrus fruits. Hematemesis, or bright red, brown, or black vomitus, is a symptom of an underlying problem and should always be investigated. Peptic ulcer disease is a common cause. Explore any changes in the skin's texture or color, such as petechiae or any ecchymotic areas, and ask about bleeding of gum tissue. Ask about lumps or swelling in the neck, armpits, or groin, and ask what they feel like and if they are mobile or fixed, and if they are tender. Primary lymph tumors are usually not painful. Lymph nodes that are enlarged and tender are usually associated with an acute infection. Determine if the patient currently has a fever, recurring fevers, chills, or night sweats. And cardiovascular disorders such as valvular disease or hypertension may predispose patients to hemolysis. Many of the medications used to treat cardiovascular disease can also cause abnormality in hemopoietic cell production or coagulation. Primary disorders that lead to hypoxemia can cause chronic stimulation of erythropoietin and result in polycythemia or excessive red blood cells. You want to assess elimination, including urinary output, diarrhea, blood in the stool or urine, a history of black tarry stools, and any recent hemoccult or colonoscopy. You will assess for symptoms of tiredness, weakness, complaints of heavy extremities, apathy, malaise, dyspnea, or palpitations. Note any change in the patient's ability to perform activities of daily living, especially as they relate to patient safety and a possible history of falling. Determine the patient's feeling of being rested after a night's sleep, because fatigue secondary to a hematologic problem often will not resolve following sleep. Arthralgia, or joint pain, may indicate an autoimmune disorder such as rheumatoid arthritis, or may be caused by gout secondary to increased uric acid production as a result of a hematologic malignancy or hemolytic anemia. Aching bones may result from pressure of expanding bone marrow with diseases such as leukemia. And hemarthrosis, or blood in a joint, occurs in the patient with a bleeding disorder and can be quite painful. In your assessment, you'll determine the effect of the health problem on the patient's perception of themselves and their personal abilities. Also assess the effect of certain problems such as bruising or petechiae and lymph node swelling on the patient's personal appearance. Question the patient about any past or present occupational or household exposures to radiation or chemicals, and if such exposure has occurred, determine the type, amount, and duration of the exposure if you can. A person who's been exposed to radiation as a treatment modality or by accident has a higher incidence of certain hematologic problems. The same is true of a person who's been exposed to chemicals like benzene, lead, naphthalene, or phenylbutazone that are commonly used by potters, dry cleaners, and individuals involved in occupations that use adhesives. Ask the patient about a history in the military. Many Vietnam veterans were exposed to a dioxin-containing defoliant, Agent Orange, which has been linked to lymphoma and leukemia. Obtain information about sexual and reproductive patterns. So, obtain a careful menstrual history for women, including the age at which menarche and menopause began, the duration and amount of bleeding, incidence of clotting and cramping, and any associated problems. Ask men if they have any problems related to impotence, because this is not uncommon in men with hematologic problems. Question the patient about sexual behavior, because HIV infection is potentially a concern, particularly among high-risk groups. Ask the patient if adequate support is available to meet their ADLs. Determine the patient's usual methods of handling stress. In the patient with a platelet disorder or hemophilia, the potential for hemorrhage can be so frightening that usual life patterns may be drastically curtailed, affecting the person's quality of life. And try to determine if a blood transfusion or a bone marrow transplant might cause any conflict with the patient's cultural or religious beliefs, and notify the healthcare provider if conflicts are identified. But also, you don't need to worry about talking about bone marrow transplants if you're just working somebody up for suspected anemia. It's maybe too early in the conversation. So back to our case study. BC tells you she's had to ask her daughter for help with grocery shopping, laundry, and cleaning lately. She said she stopped taking baths as she's afraid of not being able to get out of the bathtub. She explains that there's a family reunion planned in a nearby state next month, and that is the most important reason she is here. She's concerned she wouldn't be able to make the trip the way she feels. What are some of the questions you might want to ask both the mother and the daughter in this case? Well, you might want to ask about a family history of hematologic problems that might identify genetically linked disorders, specifically jaundice, anemia, malignancies, sickle cell disease and other red blood cell disorders, bleeding disorders such as hemophilia, and other clotting disorders. So what would you do for objective data? So your physical examination. A complete physical is necessary to accurately examine all systems that affect or are affected by the hematologic system, depending on the nature of the patient's problem, including an assessment of lymph nodes, liver, spleen, and skin. Disorders of the hematologic system can manifest in various ways. Thus, a patient's presenting symptoms may not immediately point to a hematologic problem. You might look at Table 30-5 for common assessment abnormalities. Here, you see that lymph nodes are distributed throughout the body. Superficial lymph nodes can be evaluated by light palpation. Deep lymph nodes cannot be palpated and are best evaluated by radiologic examination. Lymph nodes should be assessed symmetrically with regard to location, size in centimeters, degree of fixation, in other words, are they movable or fixed, and whether they're tender, and what their texture is. To assess superficial lymph nodes, lightly palpate the nodes using the pads of the fingers, and then gently roll the skin over the area and concentrate on feeling for possible lymph node enlargement. Ordinarily, lymph nodes are not palpable in adults. If a node is palpable, it should be small, 0.5 to 1 centimeter, mobile, firm, and non-tender, to be considered a normal finding. A node that is tender, hard, fixed, or enlarged, regardless if it's tender or not, is an abnormal finding and warrants further investigation. Tender nodes are usually a result of inflammation, whereas hard or fixed nodes suggest malignancy. It's important to develop a sequence when examining lymph nodes, such as a head-to-toe direction. Both the liver and spleen are normally not detectable by palpating the abdomen. The spleen may be more difficult to detect because of its deep location in the left abdomen. The skin should be examined over the entire body in a systematic manner. In patients with red blood cell disorders, the skin may be pale or have pasty skin tones, or have a cyanotic tinge in severe anemia. Erythrocytosis often produces small vessel occlusions, causing a purple mottled appearance of the face, nose, fingers, or toes. Clubbing of the fingers can be seen with chronic anemia, such as in patients with sickle cell disease. Leukocyte disorders may cause infectious skin lesions or malignant nodular lesions. These may occur anywhere and have a variable distribution pattern. Look carefully for petechiae, ecchymosis, and spider nevis, because they can indicate bleeding disorders. In general, skin and mucosal bleeding indicates a platelet disorder, whereas spontaneous bleeding into joints or muscles indicates a coagulation factor problem. Excessive bleeding from trauma can be due to either or both. A focused assessment is used to evaluate the status of previously identified hematologic problems and to monitor for signs of new problems. BC answers all your questions about her health history. Later in the interview, her daughter interjects, "My mom has always gone to quacks. She has a whole bunch of pills I found in the kitchen drawer. Why should you specifically ask BC to get a complete list of her medications?" Now, you should also be tactful, because there may be some tension here in the way the daughter framed her information. And be sure to use terms that the patient can understand, including herbal, vitamins, homeopathy, non-traditional, natural, in asking about everything she takes. So again, why should you specifically ask BC to get a complete list of her medications? So that you can see what she's taking and provide it to look for side effects of those pills or interactions between other medications she's taking and the over-the-counter stuff. So here are some laboratory studies that you'd likely be obtaining. This is the most direct means of evaluating the hematologic system, and a complete blood count includes several tests, each of which serves to assess the 3 major blood cells formed in bone marrow. A peripheral smear is used to look at morphology, which is the shape and appearance of the blood cells. And although the status of each cell is important, the entire system may be disrupted by disease, as well as by treatment of diseases. When an entire CBC is suppressed, the condition is termed pancytopenia. So for red blood cells, normal values of some red blood cell tests are based on body mass, so they're different for men and women. Anemia, hemorrhage, and states of hemodilution, such as those that occur when the fluid volume is excessive, can cause reduced red blood cell counts. Increases in red blood cell tests are found in polycythemia or in states of hemoconcentration, which can happen with volume depletion or dehydration. HCT, or hematocrit, determines the percentage of red blood cells compared to the total blood volume. The hematocrit value generally is 3 times the hemoglobin value. Red blood cell indices are special indicators that reflect red blood cell volume, color, and hemoglobin saturation, and can provide insight into the cause of the anemia. Erythrocyte sedimentation rate, or ESR, or SED rate, measures the sedimentation or settling of red cells and is used as a nonspecific measure of many diseases, especially inflammatory conditions. White blood cell elevation does not necessarily predict the severity of illness, but it can provide clues to the etiology of health problems such as infection, inflammation, tissue injury or death, and malignancies such as leukemia or lymphoma. A low white count, leukopenia, is associated with bone marrow depression, severe or chronic illness, and in some types of leukemia. The differential white count identifies the percentage of different types of white cells within the circulating blood. The white blood cell differential is of considerable significance because it is possible for the total white blood cell count to remain essentially normal despite a marked change in one type of leukocyte. So when there is low lymphocyte count, an absolute lymphocyte count, or an ALC, may be tabulated. When the bone marrow does not produce enough neutrophils, neutropenia occurs. A normal platelet count is between 150,000 and 400,000. Counts below 100,000 signify thrombocytopenia, a condition in which bleeding may occur. Spontaneous hemorrhage is possible once the platelet count falls below 10,000. Thrombocytosis is defined as excessive platelets, a disorder that can occur with inflammation and some malignant disorders. The most likely complication related to thrombocytosis is excessive clotting. So in the case study, the nurse practitioner orders blood work for BC while reviewing the results of her complete blood count. Which finding would be the greatest concern to the nurse? A hemoglobin of 11.4, a platelet count of 80,000, a white count of 4,500, or a red cell count of 4.5 times 10 to the 6th? Hopefully you answered B. The platelet count is significant and warrants further investigation. The hemoglobin is low but not at a critical level, and the white cell and red cell counts are within the normal range. The presence or absence of one or both of the 2 inherited blood group antigens is the basis for the 4 blood groups AB, AB, and O. Blood group antigens A and B are found only on red blood cell membranes. Blood group A has A antigens, B has B antigens, and group AB has both antigens, while group O has neither A nor B antigen. Each person has antibodies in the serum termed anti-A and anti-B that react with A and B antigens. These antibodies are found when corresponding antigen is absent from the red blood cell surface. Blood reactions based on ABO incompatibilities result from intravascular hemolysis of red blood cells. Red blood cells agglutinate or clump when a serum antibody is present to react with the antigens on the red cell membrane. The Rh system is based on a third antigen, D, which is also on the red blood cell membrane. Rh positive people have the D antigen, whereas Rh negative people do not. A Coombs test is used to evaluate the person's Rh status. As a result of transfusion therapy or during childbirth, an Rh negative person may be exposed to Rh positive blood. After exposure during childbirth, the mother forms an antibody, anti-D, which acts against Rh antigens. Rh positive persons normally have no anti-D. In subsequent pregnancy, the mother's anti-D antibodies can cross the placenta and attack the red blood cells of a fetus who is Rh positive, thus causing hemolysis of the red blood cells. A pregnant Rh negative woman should receive RhoGAM injections to prevent anti-D antibodies from forming. The laboratory tests used in evaluating iron metabolism in differentiating anemias include measuring serum levels of iron, total iron binding capacity or TIBC, serum ferritin, and transferrin saturation. Serum iron is a measurement of the amount of protein-bound iron circulating in the serum. Total iron binding capacity provides a measurement of all proteins that act to bind or transport iron between the tissues and bone marrow. Although this indirect measurement is a general reflection of the amount of transferrin present in the circulation, it overestimates transferrin levels by 16 to 20% because it also measures other proteins that can bind iron. These alternative proteins only bind iron when transferrin is more than half saturated. Also, total iron binding capacity varies inversely with tissue iron stores. It's higher when iron stores are low and lower when iron stores are high. Transferrin saturation is a better indicator of the availability of iron for erythropoiesis than serum iron because, unlike serum iron, the iron bound to transferrin is readily available for the body to use. Under normal conditions, the serum ferritin concentration correlates closely with body iron stores. In normal patients, 1 nanogram per milliliter of ferritin corresponds to 8 to 10 milligrams of stored iron. Radiologic studies for the hematology system involve primarily the use of CT or MRI for evaluating the spleen, liver, and lymph nodes. Biopsy procedures specific to hematologic assessment are bone marrow examination and lymph node biopsy. In general, these procedures are done because a peripheral blood smear is nonspecific and usually a diagnosis cannot be established from a peripheral blood smear. A biopsy can also produce additional information about a hematologic problem that is needed for diagnostic purposes as well as planning treatment options. Bone marrow examination is important in the evaluation of many hematologic disorders. The examination of the marrow may involve aspiration only or aspiration with biopsy. The benefits gained from bone marrow examination are a full evaluation of hemopoiesis and the ability to obtain specimens for cytopathology and chromosomal abnormalities. The preferred site for both aspiration and biopsy of bone marrow is the posterior iliac crest. After a bone marrow aspiration and biopsy, the site must be assessed frequently on the day of the procedure and for several days thereafter. Patients can experience some discomfort or pain and can require a mild analgesic. Lymph node biopsy involves obtaining lymph tissue for histologic examination to determine the diagnosis and to help for planning therapy. It can be accomplished by either an open biopsy or a closed or needle biopsy. Only a positive result is adequate for confirming a diagnosis. A negative result may be the reflection of the sample and not a diagnostic indicator. Testing for specific genetic and chromosomal variations in hematologic conditions is often helpful in assisting in diagnosis and staging. These results also help to determine the treatment options and prognosis. Testing is usually done on samples from bone marrow and lymph node biopsies, but sometimes from peripheral blood samples. For example, fluorescent in situ hybridization, or FISH, may be used to illuminate an abnormal extrachromosome 8 that is common in certain leukemias by targeting a specific region of DNA. Spectral karyotyping, or SKY, allows for each set of chromosomes to be painted different colors. It can be used to identify the chromosomal translocation of 22 to 9 in the Philadelphia chromosome of chronic myelogenous leukemia. Back to the case study. BC is diagnosed with thrombocytopenia. To evaluate the effectiveness of her treatment, the nurse plans to monitor what? The platelet count, the prothrombin time, partial thromboplastin time, or the International Normalized Ratio, or INR. You're correct if you said A, that you would monitor the platelet count. Thrombocytopenia is a platelet count of less than 100,000.